And welcome to our JCC meeting. It's been several months, so um, I guess the penalty is this huge stack of paper that we have, but be that as it may, we will get through the business today. And a happy new year to everybody also. And we will begin by calling the roll, please.
Yes, I'll start with you, Commissioner Chow,
Present?
Commissioner Christian,
Present.
and President Green.
Present.
All right, thank you. I will read the late acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the October 27, 2025 ZSFG JCC minutes.
So we have the minutes of October 27th before us. Are there any, well, first, is there a motion to accept?
Move to approve. Second.
And are there any corrections to it? Is there any public testimony?
There's no public comment.
Okay, all in favor, please say aye.
Aye.
Aye. Go on to the next item.
Thank you. We can move on to hiring vacancy report.
Good afternoon, Commissioners. My name is Eric Thorson. I am the Director of Hiring and Selection with the Department of Public Health. Happy New Year. Hope you all enjoyed the holiday season with your friends, family, and loved ones. Our vacancy rate continues on a steady downward trend, which I love sharing month over month. It's always good news to share. The month of December 31st, we landed at a 5.67% vacancy rate at Zuckerberg. And that's continuing down again. From about 2 years ago, we were close to 15%. So we continue to trend downward. The month of December brought ZSFG 15 registered nurses and 18 other various employees in a number of other job classes. During that same time period, we saw 3 resignations, no retirements. In process improvement news, we recently implemented a new RN reassignment process. It eliminates our antiquated emailing system where we asked candidates or current RNs to email a generic email box that they're interested in a reassignment. We've actually now created an MS form where our registered nurses that are interested in reassigning now fill out an MS form. It drops into an Excel spreadsheet and we can track it now. It's not falling into an inbox that things tend to get lost. So this is something that we're really excited about. We just started that 2 weeks ago. So we will know more about the outcome of it next month when our first reassignment process happens. So really excited about what the outcome of that's going to be. Process improvement where we can is super duper important. And speaking of process improvement, 2026 will be the year of continued process improvement within human resources. I look forward to sharing those progresses that we make year or month over month, I should say, throughout the year. That's all I have for now. Are there any questions I may be able to answer?
Commissioners?
Any public comment? I had a question.
And there's no public comment.
Yeah, I have one.
And no public comment, good.
Yeah, I just have one question.
Oh, sure, go ahead.
Yeah, I'm kind of curious, and I always get confused about this. There was something in one of the parts of the packet, and I'm not sure which it was, about traveling nurses versus, I think it was about emergency room staffing. And then there's a cost issue involved in the P103 category. I think this may come up at the commission at large as we look at budget, but can you explain the thinking or how you juggle all of that? Because obviously there are seasonal issues and there are, changes in volume of patients and so forth, but how is that? How do you figure all that out?
Yeah, and I honestly, HR wouldn't be the best one to answer that. Jillian would really be the one that would be able to give you super clear explanation as to how they balance registry or travelers versus P103s versus FTE. It is a balancing act, to your point, but I would do no justice to it, the work that Jillian does.
All right, thanks.
Is it, if possible,
She's a little square.
I'm sorry. Could you talk about benefits or the cost of P103s? I'm not sure if you're aware of because I know that they're not, I thought they weren't benefited, but they cost more and
They do, and I don't have that answer,
Okay.
but I can get that. We
Okay.
can absolutely find that out.
thank you.
Jillian's on the screen.
So,
Hi, I am here.
oh,
There she
Michelle.
is.
oh, there.
Uh, in terms of the registry and the decisions that we make about how do we use either or, we would always start with the per diem staff because they work for the city and they worked for us before going to registry. Currently, the RN registry that we are using is in critical care, and that's related to the seasonal surge, as you said, Dr. Green, that we expect every year around this time. Our ICUs, we end up opening our 4th floor ICU, and we use registry to be able to manage the additional patients in that high acuity. Usually by April, the registry contracts end and we're able to go back to continuing operations with our permanent staff.
And when it comes to registry, I mean, there's probably local and then there are the traveling nurses. How do you shop that? I mean, is it a
So-
competitive environment or is it like a monopoly in that area?
So decades ago, we actually decided that we would always go with a long-term contract only because it takes us a week or more to orient them to the environment, to the unit. And so it did not make sense for us to have as needed contracts with registry because they would come in, we would have to orient them, and then they would be gone again, obviously. So we do long-term contracts anywhere from 6 to 13 weeks. And so that falls under the umbrella of a traveling RN. And some individuals may be traveling from Oakland, some may be traveling from Texas, but they would sign up with the registry that we have a contract with, and they would come to work with us for that length of time. Again, anywhere usually from 6 to 13 weeks. And for the most part, we use the 13-week contract.
Is there much competition among companies that provide traveling nurses? Or are you pretty much, I mean, can you competitively bid it? Or, I mean, this happens in my hospital all the time. I can't tell you the number of people that sort of materialize on the labor floor for 13 weeks, you know?
Yeah, I will say that it is competitive, but recently what we have found is that individuals are not doing registries as much as they were in the past. And so we are struggling sometimes to fill some of the requests that we have for critical care. I would say 2 years ago, we had more than enough registry, as you know, especially during COVID. And with the cost that we were paying, it was not a problem for us. Recently, we found that it's taking a little longer to fill some of our requests for these contracts. And what we've been told is that that is basically what's happening around the country. I think given the economy, people are, for the most part, taking permanent positions and not doing registry as much because it's not as lucrative. And the hospitals are not signing as many contracts as they were in the past. You know, again, as you know, a few years ago, we had over 100 RN registry in the building. And today, I think we have probably anywhere between 20 to 30, if that much. And those individuals are in critical care.
Well, thank you. That was really a great explanation. I think it helps clarify a lot that's been confusing to us. So thank you.
And the only question I had was related to your exciting new process. But how many nurses do we really have that relocate or want to relocate? So that are we talking about 5 or 50 or what's that volume per month?
Great question. So the number of reassignment requests that we get, that's another perk of this new process, is that it's going to track it for us. Before it was just emails. We opened the reassignment on Friday, January 16th. On Monday, January 19th, actually I take that back, on Tuesday, the 20th, since that was a holiday weekend, we had already had 50 reassignment applications. Now, does that mean that they all move around? Absolutely not. But it does mean that that many are interested in moving to other assignments within the city.
Okay, well, we'll be interested in your update.
More to come.
Thank you very much. We'll
Thank
go
you,
on to
Commissioners.
our next item.
Sure. And I inadvertently skipped the regulatory affairs report because we thought we were going to change the order. And as Adrian's walking up, President Green, when the registry contracts come to you all, they usually come in bunches of 3 so that they have backups, just for you to know. So there's a group of them and they usually cost them out as the contracts come to you.
Good afternoon, Commissioners. Adrian Smith, Chief Quality Officer, here on behalf of Emma Moore today, and I will be delighted to present the Regulatory Affairs Report. Under pending surveys, it shows 5. We actually had 2 of those last week. So the 4A licensing and the 4A recertification happened last week after we had submitted this report. So we have 3 outstanding surveys. Recent survey activity, because this is covering a scope of 3 months, it looks like there's been a lot. So we had an FDA and California inspection of our Avon Breast Center. There were no FDA violations in that survey, and there was 1 minor quality control test that needed to be corrected in real time from the state's perspective. Also in October, we had an investigation for a facility reported event, and those were about hospital-acquired pressure injuries. No deficiencies have been identified thus far, although that survey has not been closed out yet. Also in October, we had the San Francisco Department of Public Health Environmental Health Branch semi-annual kitchen inspection. There was 1 identified improvement regarding some insulation on the pipe, and otherwise that was a really great inspection. Rounding out October, we had the California Department of Public Health visited us for a week for a complaint validation survey related to a complaint from a patient around the care, treatment, and service they had received while they were with us. That complaint was not substantiated, and the only finding that we saw from that was 1 pain medication was given without being followed up afterwards to see if it had been effective. In November, we had a labor monitoring strike for the UCSF labor strike that happened, and there were no findings there. In December, the state came to begin an investigation into the security event on Ward 86, and they exited on that today with no regulatory findings associated with that. Also on the same day, Cal OSHA visited us about the same event, the Ward 86 security event. That investigation is ongoing. And then on December the 11th, we received an unannounced visit from the Joint Commission, also associated with the Ward 86 event. They provided us with some guidance on some policy updates and some orientation updates that they wanted us to do. One of those findings was condition level, and they returned on Friday of last week and found us to be fully in compliance with the Joint Commission standards and the CMS conditions of participation. We have not submitted any plans of correction since we last met. And then before I move on to the data, is there any questions up to yet on any of the information that I've provided up to yet?
Any questions? Questions at this point?
Okay, so looking at the data, I know that the commissioners are all really interested in the things that we report and what they are. So there have been some additional facility reported incidents. There was a HAPI. There was a allegation of rape in PES, which was unsubstantiated. And there was a privacy breach in 1M where a patient's daughter viewed the chart without permission. There was a rhinovirus outbreak on the psychiatric unit, which was reported. There was an allegation of abuse from a patient who came to us from Laguna Honda and went back, and that was unsubstantiated. And then there was also an abuse allegation where a staff member was involved in restraining a patient in PES and pushed the patient. Of note, it was the RN that pushed the patient that reported himself, because after he had done it, he realized that he had overreacted to the threat that he sensed. So we're following up with that RN and with the Board of Registered Nursing and with CDPH on that. Plan correction monitoring data. We'll look at it more in the PIPS report, but we are close to closing out all of that, and we'll cover that in the PIPS minutes later in the meeting in closed session. For the complaint data, there's been no change since October on the count of investigation and their status. That remains unchanged. There have been no, apart from what we just discussed at the beginning that will show up on this next month. Prior to that, there have been no new closed events and no new open events. For the status, the same, no change since the October regulatory report. And for the 2024 status, there's been no change for that. And in 2025, we actually had 2 closed without deficiency in November, 4 closed without deficiency in in November, and 2 investigations begun in December. So those numbers look a little different from the timers. And that brings me to the end of the regulatory affairs report. I'm happy to answer any questions or clarify anything that you need to ask.
Thank you.
It's no public comment.
What's the, so on this, on the event on Ward 86, where we had all these different investigations, could you summarize what their findings are or what we're expecting we need to do?
Sure. So for the state of California, there's no anticipated deficiencies, no regulatory findings. For the Joint Commission, there were 5 findings. One was about a policy, which was wrong. Policy had not been updated. Well, the policy had been updated. It was due to be updated again this year. And there was one paragraph all the way at the bottom of the policy that was missed about where the data was stored. So that was one policy finding. There were 2 staff members on Ward 86 who were regularly DPH employees who were on Ward 86 in December, and their orientation documentation wasn't complete. They had been oriented to the space, but there was a documentation miss there. And then there was a finding around process for notification after an event that we've closed the loop on. Calosha was the 3rd regulatory body that came, and we have no idea what their findings are going to be. They began the investigation. They gave us a really big document request. They also gave UCSF a really big document request. We submitted all of those documents in a timely fashion, as did UCSF, and we're waiting for them to come back and tell us more about their investigation.
Okay, thank you for that summary. That's very helpful. Commissioner President.
Just building on that excellent question, can you explain what the jurisdiction is of these various agencies? I mean, what's Calosha's angle versus the TJC, and are they overlapping, or is it just, all of them, or it's anybody could look at anything?
That's a really great question. So when there is, we have certain reporting requirements. If someone's injured at work during during their work day, we're required to report that to Calosha. So they came in response to our report. For the California Department of Public Health, under Health and Safety Code, we're required to report the assault resulting in death or serious disability of any patient, visitor, or staff member that happens on the grounds of the hospital. So we told them about the event immediately that it happened, and they came to investigate that. And then Joint Commission have an uncanny ability to monitor news and other sources, saw the news reports about the tragic event and came to visit us because of that. However, we had already initiated our Sentinel event process because this was a Sentinel event per our own policy, and we had already begun the root cause analysis when Joint Commission arrived. And I think the seriousness of the event prompted all of the visits, but our prompt response to the event and the fact that even though much of the work hadn't been completed at that time, it was obvious that work had begun and there was a focus and the organization was, taking this very seriously and making changes to create an environment that was safer. That affected the severity of the findings for the Joint Commission and for CDPH. I will say that the Joint Commission and CDPH main focus is patients, but they are concerned about the environment that patients are in. Cal OSHA's main focus is employees, so we'll see. That's why we see a lot of, and we will continue to see focus from that regulatory body from a different perspective to the first two.
Thank you.
Thank you. Yes.
Thank you for
Commissioner
the
Christian.
report. Can you explain the notification process
Sure.
hospital goes through?
So for the California Department of Public Health, we have 24 hours to report some events and adverse events, and we have 5 days to report others. This met the criteria to be reported within 24 hours. The event happened on a Thursday. We reported it via telephone on the Thursday and followed that up with a written communication on the Friday. By Cal OSHA, if a staff member is admitted to the hospital whilst on duty as part of their job, we're required to report that to Cal OSHA within 8 hours of their admission. So again, that was reported on the Thursday evening.
Whose responsibility is it to make the report? You said that this one was by the phone the first time. And
It's the quality management department,
Quality
regulatory affairs, work with hospital leadership. In office hours, a phone call or a page is made to someone on duty in quality management. In the off hours, our risk management department, it has a 24/7 pager, and then the hospital AOD or other people can page that number, and those reports are made that way.
And I would imagine that the state also has a 24-hour notification process.
The
They
state
can
work
receive the
Monday
notif-
through Friday, office hours.
Oh,
So if something's reported after 5, they pick it up the day after.
Hmm.
If it's reported after 5 on a Friday, they pick it up the following Monday.
thank you.
Any
Uh,
other questions?
If
Commissioner?
there are no further questions, we can move on. Thank you very much for the update.
Thank you.
Thank you. We can move on to item 5, the CEO report, Emergency Department newsletter and Burt newsletter.
Good afternoon, Commissioners. Susan Ehrlich, CEO of the hospital, Zuckerberg San Francisco General Hospital. Happy New Year. It's good to be back with you after all this time. Like every other part of this report, it's quite long, and so I'm going to be selective about what I talk about. And of course, I want to talk about Alberto Rangel and the event that happened on December 4th. It's impossible to overstate the impact this has had on ZSFG in so many ways. The regulatory response is just really the tip of the iceberg. And I do want to say that I am so incredibly grateful to Adrian and Emma Moore and Emma Iwanaconda. The skill, grace, and compassion with which they stewarded all of the work involved in responding to the event, responding to the regulatory agencies, doing the root cause analysis is really just extraordinary. It couldn't have been a more stressful situation. In many ways, it continues to be. I'm very grateful for the department's embracing of this event and, really responding all in on it. And you'll hear more about that during the security update. But I just want to say how horrible it was to lose Alberto. This was a tragic, terrible event that never should have happened. And we will do our best to honor him by making sure nothing like this ever happens again. And I feel very good about the response that we are doing as a hospital and as a department to put a lot of pieces in place that need to be put in place to make sure that that's true. And I'm happy, of course, to answer any questions about it. But I think a lot of them can be answered by the security presentation that's going to be given in a few moments. So moving from that, the other thing I wanted to highlight is the go live of Beaker, SoftBank, and the automation track. This happened, it feels like a lifetime ago, but it was really something. It was an incredible accomplishment of our lab, both the clinical lab and the public health lab, and the pathology lab to go live. This is, and we knew this in August of 19, this was always going to be the most complicated go live of Epic. And it really was. And it wasn't enough to just go live with the Clin Lab, pathology, and the public health lab, but we had the automated track installed at the same time, which is a giant, complicated, and magnificent piece of equipment that helps us process our lab specimens more efficiently. So all of this together was really quite an undertaking, and it all went off smoothly and without a hitch. So very grateful to our IT partners, to our lab partners, and everyone for getting that done. I'm going to skip through all the other wonderful things that are in here and just point out that we have a lot of new leaders who were appointed during this time. So to start with, we have Kim To, who was appointed by Adrian as our Director of Performance Improvement. We had one of our nursing managers who was appointed to Nursing Director of Maternal and Child Nursing, Shilu Ramchand. We have a new UCSF Medical Director for Risk Management and Regulatory Affairs. She's already started working in this around the Ward 86 event, Dr. Carolyn Hendrickson, who is a critical care provider. Recently, we appointed Dr. Andreas Mitchell, who is a primary care doctor, as Medical Director of Performance Excellence and Improvement. In the emergency department, Matthew Talmadge, who is one of our nursing managers, is now the nursing director in the emergency department. We have a new director of food and nutrition, Adrian Gonzalez. Our own Dr. Mary Mercer won the Values in Action Award. Very excited about that. And there's one other person who was appointed. Dr. Marlene Martin was appointed as our physician chief for care experience. And we will have a proper announcement in the next one, but because she's already been appointed, I wanted to point that out here. Very excited to be surrounded by these incredible leaders. I have worked or will be working closely with all of them, and it just makes me even more proud to be the CEO at ZSFG. And with that, I will see what questions you have on the narrative report before I go into the data.
Commissioners? Yes.
Thank you for the report. It's good to see you. Just wanted to note that the Community and Public Health had a presentation from the lab team, and it was so impressive. And just want to congratulate you for the complete success so far of that update and that new equipment. So I just wanted to note that.
Yeah, and pretty soon we'll be welcoming the public health lab into the ground floor of our building 5, which is very exciting. There's a lot of very complicated construction work, exhaust construction that's happening now to accommodate them. So they'll be moving over slowly over the next couple of years, and it'll be really nice to have them with us.
I also wanted to thank you for your overview of what is going on with the security updates and what's happening at the hospital. And thank you and your team for how you are handling the situation and moving forward.
Thank you. Really appreciate that.
Good.
Okay, so I will, I'll start on the data and a couple of the questions.
Oh, Dr. Early.
I'm sorry.
Dr. Green.
Well, no, I just wanted to echo what Commissioner Christians said just now. And also, it's just so impressive every time you tell us about the diverse individuals that are taking these various positions with, again, diverse responsibility. The quality and the experience and the credentials are incredible. And people come because of the, they may come for the mission, but they stay for the people they're working with. So I mean, this is really wonderful. Every time you bring people to us, we're mightily impressed.
Thank you. I am also impressed. It's very humbling and it's really a delight to be working with all of these talented individuals.
Okay. Thank you. I'll echo that. The organization obviously is quite complex, and even the documents you gave us in terms of all the different departments really show the complexity, I think, and the strength that the hospital has in terms of the key, which is the personnel. So thank you very much.
Thank you.
We'll
couldn't
proceed
do it
to
without your
your
support.
next data
Yes.
report.
Okay, so the data, it's always very exciting. I wanted to start actually, Dr. Chow, by addressing your question about, or Dr. Green, sorry, about the BERT activations. This is very interesting. It makes sense that we might have seen an increase in activations. And we actually did. When you look at October, November, and December, we had 87 activations in October, 88 in November, and 111 in December. The thing about interpreting that, though, is it's not really clear why, right? Because we often have an increase in December simply because of the volume in the hospital. And really, our volume has been higher in December, or was higher in December. So I wouldn't feel comfortable attributing this to anything other than the volume until we've had a chance to see more of the trend over time. But yes, we did see an increase in activations. Okay, so going.
Well, just stopping there for a moment.
Yes.
The one thing that 3 months did was that we were able to look at 3 months, and it was very, very impressive, especially with the number that you say actually were successful.
Mm-hmm.
So
Yes.
I think from what you were just saying, then we probably need something that says, number per 100 patients or something, so that we can get into what you were just saying in
Yeah.
terms of, is it that, and it could be more people find this is really helpful and useful. And it's great for the large number of people that were in need of this, that you were so successful. And that also we did not have to use law enforcement,
Yes.
which as in the past, we've had a great deal of problems on the floors, and because of the training that both law enforcement has versus a dedicated staff like that. So I think at the same time, I believe that what this is a program that's in other hospitals throughout the nation, right?
Not many.
Mhm.
I haven't done a full count of it, but when we first started BERT, there were a few around the United States. I'm pretty sure that that's increased since then, but haven't done a dedicated report to see how many are there. It's definitely been a game changer for us. I do want to just point out, though, that we have a dedicated team in the emergency department. And we have a second team that responds to other incidents in buildings 5 and 25. We don't as yet have that resource in buildings 80, 90, or anywhere else on campus, but we hope to as part of the security investments. But that's still to come.
So it might be good actually to focus on Bert, including perhaps what the nation's experience has been, how we kind of stack up with that, being one of the pioneers, therefore, and that this is really a lesson for others in terms of how to handle it. And be really interested if any of our local large organizations in the Bay Area or even in the state have found similar experiences or how well we've done. Because I found that when we looked at, like I say, sequentially, this opportunity over the 3 months, it was really quite impressive that continued to show effectiveness.
Yes, yes, it is. And it's really particularly impressive when you see what they do firsthand. Because you can take they can take situations that seem like they're going to just spiral out of control and result in, potentially somebody being injured, a patient not getting the care that they need, and they can just calm it all down and things can go very smoothly. So, as usual, I'm not the subject matter expert on this, but I think at some point it would be good to bring information or a presentation back, whatever you prefer about this program.
Right. I'd have you work with Mark on what might be an appropriate time, because I think it would be good to get now kind of an overview since how long have we had it now? It's
Oh,
what, 3 years?
well, it started as a smaller pilot, like many things do, and that might have been 5 years ago, or maybe longer, but it's been, as big as it's been for maybe 3. I don't even know exactly, but we can get that information
No,
back for you.
that'd be great, I think.
Yeah.
Okay. I'm sorry, proceed.
Okay, so starting with equity, this was this is an area where you had a question, Dr. Chow. And I just want to point out, higher is better here. We exceeded our target, 69.5% over 65%. But as you pointed out, Dr. Chow, we were almost 11% lower than we had been the year before, and you asked why. There's not, recall that this metric is the percent of departments in any month reporting to PIPs who are reporting a driver for equity in their departments. So there's not a single thing you could point to. It really depends on what are the departments that are coming forward in that month, and how easy or appropriate is it for them to choose an equity driver, and do they choose an equity driver? So it's a little bit hard to say what exactly would have caused any month to be lower or higher. So there's no single cause that I can identify, but what we want to see is that overall we're, at least getting to the target that we picked, which is 65%. It's hard to identify a single thing.
Okay. I'm just wondering where we're going to go with this, or
Yes.
is there a more specific type of measure that would give you more quality in terms of what's happening?
Well,
Right.
interesting that you mentioned that. I think we will likely rethink this one. I mean, we do with all of ours. We're continually thinking about what's the best way to measure whether we have impact or not. And now with the Department of Public Health being very focused on which areas it's interested in driving reduction in disparities, it would be appropriate for us to really focus in on those 3 areas, which have to do with preterm births, cardiovascular outcomes, and overdoses. And we have work going on in those areas, but it may be a place where we want to think about this in particular and how we're focusing on those 3 areas. So more to come.
Okay.
But, there's a lot going on right now that gives us an opportunity to think differently, I think, in the scheme of what the department is doing about this particular metric. Because as you know, we've kept this one the same for quite some time now.
Yes. And well, that's where I was trying to wonder where we would then go, or take the lessons from that, or move, like you were saying, towards a more focus,
Yeah.
which would then, because you know, the measurement makes sense and in the sense that it encourages different departments to at least select a measure because certainly in healthcare, equity is a really big issue,
Right.
regardless of whatever the national sense may be.
Well, we want to be the healthiest place on earth for all people. So we will work on
Okay.
seeing how we can contribute to that.
Thank you.
Moving on to sepsis, this is, as you know, a place where we've had some trouble, but we have begun the EPIC build for the sepsis care bundle, so we expect to see improvements in this upcoming. This one, higher is better. Our target is 59%, and we're just at 42% at this point. A little bit higher than we were in 2024, though. Okay, so falls, this is a metric that we're actually going to be retiring. We're working on our new set of metrics to present to you. This is one we'll be retiring. It's great because we actually met our target here, which at one point in the past seemed like it was undoable, but we have been able to do that. MOUD, this is very exciting. There's a lot of work going on in this area. You can see by the nature of the curve that we don't have a clear path for improvement at this point, but there's a lot that we're doing to be aligned with breaking the cycle. Our target, obviously here, higher is better. Our target is 22, we're at 19. We are about the same place that we were last year. One of the things that we're doing now, or the emergency department is doing, led by Dr. Mercer and others, is to increase starts of Brixadi, which is a long-acting injectable drug, in the waiting room of the emergency department. We've been pretty successful of starting in the emergency department, not necessarily in the waiting room, but any improvement is good improvement. And one of the things that is really cool about this is that now we have our addiction care team nurses who can consult on these cases from anywhere in the hospital, and they're available for that. There's a pager that any nurse or physician could call to get them to, come and help with any case, in addition to the ACT team, that's the inpatient consult team. So I feel we're not meeting our metric or target here yet, but I feel that we're on the path to doing so with a variety of different things. Length of stay, also we have not hit our target. Here, lower is better. Our target is 5 days, our rolling 12-month, we're at 6.31. There's a lot of work going on here. You can see a slow downward trend, and you can also see that we've had a slight improvement from the previous year. One of the things that I will point out is that we added additional MRI shifts to decrease the time to getting a study, especially if you're inpatient, and if that study is going to hold you up from being discharged. There are many things like that we're looking at, and just wanted to point that one out, because that was a big lift for the radiology team. I'm not going to say a lot about the psychiatry ones. We've been meeting those metrics for quite some time. So that's a good thing. Boarding. Okay. So boarding is still a big problem for us, especially this past couple of months. It's been terrible. So here, lower is better. Our target is 15. Our rolling 12-month is 29. I will say, though, that we've had a 25% reduction from the previous year, which does represent improvement. And in fact, in one of the last slides we'll talk about, you'll see a pretty big improvement in lower level of care days, which is related to boarding, because boarding goes higher when it's harder to discharge patients from the hospital. So I do feel we're making improvement here. You can see boarding in January of 25 was at 35 on average. Now we're at 26 in December. So you can see that steady improvement. We're not there, but we're moving towards it. Physical assaults with injury, obviously, this is a huge deal for us. Here, of course, lower is better. Our rolling 12-month is 5.2. Our target is 4. We have had some improvement from last year, about 24%, so that is good. But any assault with injury is not what we want to see. And there's a variety of work. Again, I'll defer to the report that's going to be coming up in a few minutes. Okay, accounts receivable, the financial metrics, we're doing okay on accounts receivable. We're below our target there, which is good. Lower is better. But percent realized revenue and denial rates, they're actually related to the question that you asked, Dr. Green, and I sent information about that. And the root cause of the issue here is how the health plan is handling some of our claims. And we've been working on them. We've pointed out to them that a problem exists. They have acknowledged the problems and they've not fixed the problems. So your question actually helped make that more clear, and that it likely needs some escalation. So we will be working on that. Thank you for asking the question. Okay, so I'll stop there and then get to the flow data. Any questions on what I presented so far?
Questions? Yes, Commissioner.
It was really interesting, your comment about the long-lasting injectable and how it's being administered now in the waiting room. Can you say a little bit more about how that comes to pass?
Well, we have an expert here who can say more about that. Dr. Mercer?
Thank you so much. So we've taken a lot of different approaches in terms of incorporating best practices from around the Bay Area and nationally. Some of our colleagues over at Highland Hospital, we went and did a site visit there, and what they found is, because the waiting room is a very busy and also not entirely private place, they have a lot of passive messaging to patients while they're waiting, because what we have found in a lot of our case reviews of missed opportunities to offer people treatment for opioid use disorder is in the emergency department is that patients may not be comfortable presenting with that as a concern, as among their primary concerns. So they might be there with a rash or a cough or another medical concern, but we have passive advertising that says, if you're interested in talking about this, ask your clinician. And so then when they are screened in the left without being seen data, you've seen we have increased providers in the waiting room area that have a private area for patients to talk with them. And so then they can bring up that item. And then in addition, a number of our areas, particularly the psych emergency room, has some screening, active screening of patients for opioid use disorder. So it's actively offered by the clinicians.
That's fantastic. Thank you.
Just another example of our creative and resourceful patient teams. Okay, so going on to the flow data, I think I'm going to focus on ambulance diversion. So a couple things that I want to say about this. Dr. Chow, you asked about why diversion is up. Well, it's winter. And winter brings, more illness, more critical care patients. It's just a very busy time. And in fact, I'll say we saw this increase in December. It's going to be, unless things change a lot real soon, it's higher in January. But and there's two things that drive boarding. It's that drive ambulance diversion. It's boarding and it's staffing. So as you've heard, the staffing has been impeccable in the emergency department. So that's, for a while now, that's rarely been an issue. And we've really had some remarkable improvements earlier in the year because we've had, relatively good flow and very little boarding. But I would just point out that if you look at January 24, January 25, and December 25, you can see really pretty steady improvement, right? Because look at the peaks. These are the winter peaks. You can see 3 on the graph. So in January of 24, we were up above 69%. In January of 25, we were above 56%. And December now we're at 46%. So what I'm hoping is that, we continue to see a steady decline over time, especially in the winter peaks and then in the times between the winter peaks.
That's fine.
Does that respond to your question, Dr. Chow?
Oh, yes, yes. I just wanted to keep it on our agenda.
Don't you worry, it will be there. I think, you know, most of these data are either steady or reflect the seasonal increases that we see in December, January, and we'll see again in January and February. The only other thing that I wanted to point out is what I mentioned earlier, which is this really nice decline that we've seen on the med surge side in lower level of care. It's still not where we need it to be, which is that line across the bottom, but we've definitely made some improvements thanks to a lot of people in the hospital who are working to improve that. Psychiatry still is representing a problem for us, and we had some, you know, earlier in last year we had some improvements from previous, but that's going to continue to be an issue for us. Hopefully, when we finish the behavioral health center project and we have twice as many LSAT beds, we'll make a big dent in this problem. Any questions? Any other questions?
Yes, Commissioner Christie?
Thank you. Is there currently an estimate on when the behavioral health center will be ready?
It's a couple of years away
Couple of
because
years.
there are a number of different things that need to happen,
Mhm.
right? The patients who are currently in the RCFE are going to need to move into 624 Laguna
Mhm.
or elsewhere for their preference. Then there's going to be capital improvements that need to be made, and then there'll need to be, you know, restaffing. So it'll be a couple years away.
And right now, there's no interim relief of any kind that is not necessarily related to behavioral health center, but any other beds.
I know that, you know, my colleagues in behavioral health are constantly looking to expand the beds, and they've made some expansions in beds of various types. The beds that we need most of all coming out of psychiatry are LSAT beds. That's the biggest group that we need. And on any day, we have, you know, 10 to 15 people waiting for
Right,
those types of beds.
right. 10 to 15.
Yeah, and that's the hardest kind of bed for them, for behavioral health to purchase, as I understand.
Thank you.
Sure.
Any further questions? No. Okay. Thank you very much again for
Thank you all for your support.
And commissioners and Commissioner Child, there's a, excuse me, a member of the public here, and I'm wondering if we can move up public comment so that that person could provide comment, and then we could continue on since the items that we're moving into are going to be somewhat lengthy.
Oh, surely, of course. You have the name of the,
Oh, yeah, no, well, he will come up and go. And just so you know, it's a 3-minute time. I'll do it. And there's not a back and forth. So if you're talking, they're not going to respond to you, but we will be taking in what you say.
Got it. Thank you.
Great.
surely.
And if you could introduce yourself and where you're from, and I will start the timer.
Chair Chow, Commissioners, my name is Jonathan Froxwhite. I'm the Director of Health Justice Policy at San Francisco AIDS Foundation. And I'm testifying today to request this committee's support for San Francisco General providing routine opt-out HIV testing in the emergency department. Routine opt-out testing, or ROOT for short, means testing all patients unless they meet certain exclusion criteria, rather than only some patients who meet certain inclusion criteria. It also means offering patients the opportunity to opt out of testing rather than requiring them to opt into a test. Research on routine opt-out HIV testing in emergency departments has found that this practice identifies HIV infections at a higher rate than testing focused on populations at higher risk of HIV. Based on these findings, both the California Department of Public Health and the CDC formally recommend routine opt-out testing for HIV in emergency departments. It is a best practice. Unfortunately, the ED at San Francisco General doesn't follow this practice. Since the emergency department is likely the only setting where some San Franciscans living with undiagnosed HIV access care, the lack of routine opt-out testing in the ED means that the hospital is likely missing opportunities to diagnose people living with HIV and link them to care. In fact, San Francisco epidemiological data suggests that each year, a number of people who are newly diagnosed with HIV previously received care at a San Francisco ED without being diagnosed. In October, a coalition of 9 organizations sent a letter to San Francisco General leadership asking the hospital to implement routine opt-out testing in the ED. They recently declined, citing operational challenges and costs. Although we acknowledge that there would inevitably be some challenges and modest costs associated with implementing Root, we believe these barriers could and should be overcome. For proof, we can look to the almost 30 other California hospitals that recently implemented Root in their emergency departments as part of a state program, including regional peers like Highland Hospital and UC Davis Medical Center. San Francisco General has a long history of leadership in our community's response to the HIV epidemic. We hope that the hospital will continue this strong legacy on HIV by implementing routine opt-out HIV testing in the emergency department, and we hope this committee will support that effort. Thank you for your consideration.
Thank you. And again, we're sorry about your access issues. The door was locked when he came today. So thank you for your patience. All right. That's the only public comment for today. And we can move on to the security update. And I will pull up the presentation.
Who's going to give that?
I am not sure. It's like, I thought 2 might. I believe Mr. Smith will be right back.
Oh, okay.
Hi, Commissioners. I'm happy to wait for Adrian, or I can start, either, whatever you prefer.
Sure. Let me have pull it up.
Why don't you start and then we'll have Adrian fill in
Absolutely.
as needed.
Good afternoon, Sabrina Robinson, Chief Operating Officer at ZSFG. Thank you for your time today as we talk through the security update.
It's okay.
We would like to start our presentation. Hi.
I'm being tardy.
We would like to start our presentation by remembering our dear staff member, Alberto Rangel. On December 4th, the ZSFG UCSF community suffered this devastating loss. And with that, we would like to have a moment of silence for Alberto. Thank you. I'm going to defer to Adrian as the Deputy Incident Commander to the IMT structure. You can go to the next slide.
So immediately after the event, it was apparent that we needed to address this and we had to get it right. So we had to have experts in the room to make good decisions and people that could make decisions and move resources and make plans quickly with authority. So we put together an incident management team. Andy Tenner from FEFA came as the incident commander and immediately identified that one of the biggest parts of this was going to be understanding what happened and the regulatory response. So I was appointed as deputy incident commander in the structure. We stood up our normal structure underneath the incident commanders with planning, operations, logistics, and finance so that we could plan, and then we could do, and then we could learn how to pay, and then we could move the resources around from a logistics point of view to make that happen. As that structure developed organically, we identified that we needed some strategy because we didn't want to just look at ZSFG. We wanted to make this a DPH-wide response because we were learning quickly that the patient involved in this incident, like so many of our patients, touches multiple parts of our of the care treatment service that's delivered, not just by the San Francisco Health Network, but by Pop Health and by behavioral health services. So the org chart that you see in front of you reflects people from all parts of the Department of Public Health and from our partners at UCSF, because Alberto was a UCSF employee working in a licensed clinic at ZSFG. We can go to the next thing. One of the most important things that we identified was that we needed to stand up a more robust threat management process, and we we defer to our Director of Security, Basil Price, on this, and he helped us to identify additional resources that we needed, and we needed to mobilize those additional resources very quickly. So for the threat management team, we went from a team of 1 to a team of 5 very quickly. That team also began to create really rigorous process that wasn't just operating in business hours, but that was a 24-hour response. And this org chart gives you an idea of that expansion. The threat management team wanted to give staff something simple and something that would provide them with response. So we triaged that into 2 responses: immediate threats or emergencies, and non-immediate needs and safety concerns. So emergencies, it's a single number for staff to call that takes them to the Security Operations Center at ZSFG for Laguna Honda and for ZSFG, and the San Francisco Sheriff's Department can dispatch officers to the area of concern if there's immediate danger. Outside of the 2 hospital campuses, it's a 911 call, and sheriffs respond to that. On campus, across DPH, that we then set up the safety concern line, which is a 24/7 line. The intent is for each call to be answered, but the promise is if it's not answered and it goes to voicemail, there's a return call made within 30 minutes. And the structure is for staff to call this number if there's a perceived threat or need for support, but that threat or that need of support can wait for 30 minutes. So for those patients that are escalating over, expressed a concern, made a threat, but they're not present in front of the person, and there's no perception of immediate threat to them. We have within that structure, you will see more as we move through this process, but a dashboard is being built so we can monitor how many calls we receive, what the outcome of those calls are, and then the loop closure from those calls. So that team don't just take in the call and deal with it in the moment. They follow back up with the person that made the call and with the leaders in the area where the event is happening. It's a multidisciplinary response. So if it involves a patient, their care team's involved in the response as well. And it really provides a support mechanism for our staff who deal with some really difficult patients, and for our patients who go through some really frustrating interactions where one part of DPH can't answer a question that another part can. So this can help with bringing people together so that the right messaging can go to patients too.
If I may.
Of course.
Also, as soon as the incident occurred, when the IMT structure was activated, we set up a security email, an all staff email. And the purpose of that email is so that all employees across DPH can voice their concerns about what they perceive as a threat or an issue related to safety. We have analysts looking at that email inbox and look at the email inbox daily. Since the activation of this email, we've had over 3,700 emails with 27 different themes across DPH. And there are a top 5 themes that we are addressing real time across all the different departments and also in the IMT structure. Campus improvements, sure. So we have reported to you, commissioners, that safety is one of our main priorities, not only across ZSFG campus, but across DPH. So I would like to mention that in our past presentations, we have mentioned to you what our workplace safety, our workplace violence committees have done in collaboration with facilities and risk, our UC partners and law enforcement partners. So some of these items that you'll see are in addition to or in conjunction with some of the work that we have already identified, and we're enhancing it. So it's giving us another set of eyes to ensure that we are doing the right thing in real time. specifically as it relates to Building 8090, where the incident occurred, we immediately recognized there to be some opportunities for improvement. The 8090 area, as you're well aware, is adjacent to the campus across the street. And we were trying to quickly deploy different things, which we're going to go over shortly, prior to the incident, but more specifically, I'm very, very proud of how the team came together to deploy these updates, specifically, again, related to 8090. This particular building is a very old building, one of our brick buildings, but it was very porous. It's a maze when you walk in there, and it's very easy to kind of get lost. And so one of the first things we did was we isolated to one single point of entry, and we closed off the Potrero entrance. The ADA entrance that's in the back is just for ADA patients. And so now we have everybody going in through one point of entry. We have told you about our evolve system in buildings 5 and 25, and building 8090 was next on the docket with regard with implementing the weapons detection system in the first quarter of 26. And I'm just really happy to say within probably 10 days of the incident, we were able to deploy it. And so as everyone who walks through building 8090 through the one entrance, as they enter, they are walking through the evolve system. Lockers and navigators have also been deployed. So we want to be extremely conscious of the fact that there needs to be a balance between our safety and also our patient care. There are a variety of clinics that are in building 8090 that the patients have a variety of needs. And we have OTOP, we have Bridge, we have the methadone clinic, and we want to make sure that the patients still felt welcome. There was a significant change. So as you walk up to building 8090 and you saw increased security presence, which was a combination of a multidisciplinary team of cadets and contracted security and sheriffs and our ambassadors, it could be a little bit intimidating. So what we did was we implemented lockers before you go through the weapons detection system, and we explained to the patients that this is for your safety, and just in case there's something that you do not want to be detected, not from a safety perspective per se, like a weapon, but more from the lines of, I am a recovering addict and I might have a needle and that might be perceived as contraband. So, managing that and balancing that. And actually the lockers on the outside have been very, very used. As a matter of fact, we went from 8 to 15, and then we were using buckets and garbage bags. So as Adrian mentioned earlier, it's an evolving process, and we plan and intend to get better every single day. So additional campus improvements is enhanced security, security campus-wide. You may have heard of Allied. So we use Allied primarily as our second observe and report contracted security, but we also have Marina Security, and Marina has actually increased their posts and have been extremely helpful with the additional posts that we have added across the campus. Again, not just 8090, but our campus goes from CHN building all the way to the Behavioral Health Center. And so we've added rounding and rovering up and down into 8090, CHN, a number of posts, and Marina Security has been very instrumental in that. We've also increased the presence in the ED ambulance bay, the presence in the parking garage, which is also very vulnerable. That's managed by SFMTA and LAS. We've made physical plan improvement, lighting improvements, call boxes. So in the parking garage, for example, there were call boxes already installed. People didn't know where they were. When we tested it, we realized they were going to a third-party company. So immediately we changed the call to go to the security operations center on campus, so that could be a faster response. Lighting improvements have been underway across the campus. It is still very interesting to me how long it takes to get things like LED light bulbs. But if you ever come on the campus, you see these large stadium lights, and those were already in process of being updated because they've been broken for several years. But more specifically to 8090, I think within maybe 2.5 weeks, we were able to first put temporary spotlights, and then got our electricians to put additional lighting and call boxes. Again, additional work in progress because there are still crevices that we're trying to make even lighter, because that's a natural deterrent when you have spotlights on certain areas. But more immediately, we're already seeing these improvements campus-wide. Policy review, data dashboard, EHR, FYI flag, and Adrian and I will tag team on this one. But in the IMT structure, we're evaluating all of our policies, establishing additional policies, enhancing our policies that we already have. And also, a policy is just a piece of paper. So to ensure that we're actually enforcing the policy is what we're also focused on. So this DPH-wide effort through the IMT structure to look at all the threat management team policies, and you are already aware of our PIPS review and how we process policies. And
I think one of the first policies that we've seen go through is the overall governance of security operations governance, and how security issues throughout DPH have a clear pathway to a centralized committee and a centralized group of leaders and experts that can help support local development, local implementation of ideas. So that's one of the first policies that's going through the approval process, and that's going to be DPH wide. And I think that was really important. And then we've just been looking at, there have been multiple ways to achieve the same thing in different parts of DPH. So standardizing that has been really important, so that if you're a provider or a nurse or an administrator that visits an offsite location or a new location, it's the same number to call if you see something. It's the same process to follow, and you're not going to hear unique acronyms if you're in X clinic compared to Y hospital.
mm-hmm.
The data dashboard is going to be really, really important, because it's how we're going to know what we're doing to making a difference, and that we're investing the resources, the time and the energy in the right place. So it's really building upon the ZSFG Project Phoenix work that's moving a lot of our data into a Power BI dashboard, and the IMT structure have used the same framework to begin to build that dashboard around security events, security response, and all of the other improvements that are being made. And then I think the last piece that around this is communication is so important and so difficult. When a patient visits City Clinic and then goes to Potrero Hill Health and then goes to one of the hospitals, like, those people all chart in Epic, but they chart in different ways in different parts of Epic. But Epic has a way for us to have flags built in, so that if there's a risk or if there's something other providers need to know, they can see it in one place. We want to do it centrally, so we're really thoughtful that we're using our equity lens about how a flag's placed, and then how it's reassessed and removed if certain criteria are met, because we don't want. One of the things that has become apparent is some of the flagging that is happening in our version of Epic and other organizations' versions of Epic has bias associated with it, and we want to try and eliminate some of that bias. I think that Angelica and Sabrina have been working with the Institute for Healthcare Improvement and partnering with hospitals nationwide to understand what their best practices are, and those relationships that were already being built for over a year have been really important to check ourselves and say, are we trying to reinvent the wheel, or is there something that we can use from another organization?
And also, if I may, we want to be very intentional. And so we also know that there are different employees that don't have access to Epic. So we want to make sure that the same message that is being delivered in Epic on whether there is a vulnerability or a risk, of a patient risk, is also very visible to the EVS worker or the food and nutrition worker. So we're working on that as well.
If we go to the next slide, such an important part of this response has been staff support and staff engagement. The staff directly involved in the event from Ward 86, that they have exhibited a trauma-informed response in the way that they have struggled to really, be able to put into perspective and understand what's happened. And then it's been campus-wide and DPH-wide. We have seen similar exhibitions of trauma-informed response, of grief, of fear, of overwhelming support. But one of the things that we knew was super important was to provide support to people. So whilst as an organization we provide benefits, we also have an EAP program. It was above and beyond that. So Angelica Almeida from ZSFG and Star Knight from UCSF really led this work, and we were very, very lucky to have a lot of support from behavioral health services who brought in mental health clinicians and specialists to round on the units at ZSFG, to round in offsite. There has been individual support and group support. A healing space was stood up at ZSFG and is being stood up out so for people that work off campus and in other parts of DPH can have a safe space to go. And I will say that leadership at DPH level have put a phenomenal amount of time and thought into town halls, staff debriefs, and email feedback. The communications department set up a weekly security newsletter. Dan Sy has had regular town halls. Susan Ehrlich and Jeff Critchfield from the Dean's office have had numerous CSFG town halls just to share what's happening with all of this, with the staff, so that they can feel as informed and as involved as we can help them to be. Sabrina also talked about that staff support email. HR have taken the lead with that, and I have to really give a lot of kudos to HR, where those emails were being responded to individually and acknowledged to say that people had got them. And that was a huge lift from a resource perspective. And working in quality management, working in risk management, the concept of third victim. The first victim is the person it happens to. The second victim is the people that were there and gave treatment. The third victim is the people that hear about these terrible events, these terrible circumstances. And it's a real kind of trauma for the third victim. So having the ability to provide support for all levels of effect on this has been so important. Our last slide talks about investigation. So the IMT process has been an active investigation in the way that we've delved into process, delved into policy, delved into discovery of what happens in different places, how calls are routed in different places, what happens if you call 911 from a cell phone as opposed to a landline, and if you call it from a cell phone, you're 2 times more likely to go to CHP and not a local dispatch office. I didn't know that. Depending on which cell tower you ping off. So a huge amount of discovery went into this. There were the regulatory investigations, so CALOSH is still ongoing. CDPH closed today. The Joint Commission closed on Friday. The ZSFG root cause analysis secondary to a Sentinel event. The dissemination of the countermeasures is ongoing for that. There's a criminal investigation, and SFPD are leading that. We're being really thoughtful about what we share, that we don't jeopardize the criminal investigation. And then there is a plan through the City Attorney's Office to also, in parallel to our own internal investigations, assessments, to have an external security assessment come in. Just like a survey, and a fresh set of eyes can show us things that we either miss or prioritize in a different way. So that process is also ongoing. Anything else to add, Sabrina? I would love to answer your questions.
Thank you for the presentation and for all the work and attention that you are, the amazingly thorough and thoughtful work and attention that you're doing, you and your team. Looking at, and thank you, this is a very helpful and thorough presentation. So looking at page 4, the threat management team. So this is staffed from 1 to 5?
Staff are in-house from 1 to 5, but the number's 24/7 and there's someone on call answering that number 24/7 for the 30-minute response time.
Okay, so if I am an employee working anywhere on or off campus at 9 p.m. and something is happening, and is there somebody like staffing threat assessment at that hour?
Yes.
Okay.
Yeah. So if you call the 64911 number, you'll get through to the Security Operations Center if there's an immediate threat. If you have concerns, if you're on the street team, if you run a late clinic, if it's 9 o'clock at night and you're just doing your documentation and you look back at a patient, you think, I'm worried about this patient's appointment tomorrow or after the weekend. That number's 24/7, so you can call. If they're busy on another call, it will go to voicemail and they'll call you back within 30 minutes. The data up to yet has backed that up. Every call bar 4, I might be misspeaking about the exact number. Nearly all of the calls have been answered. The ones that haven't, it's 4. They have been returned within 30 minutes. That's a real person you speak to. It's one of this team. The people on the team have real life law enforcement, behavioral health, and security experience. So it's a mixed team, and they take the initial intake and can give help, advice, and support. For instance, if you called and it was myself and you were concerned about a visit tomorrow that you weren't going to be around, but the patient had made some vague threats or vague kind of, dissatisfaction with care and disparaging comments towards another provider, you could call us. We would take that and we would listen. We would identify the risk and threat level for the following appointment, and we would work with security services, whether it be law enforcement or on campuses where there are private security. We would have someone on standby for that visit. And each call would be done individually. Not every call gets someone dispatched. It depends, and they have it's like 40-page standard work with multiple different scenarios that they follow for that, but it's available 24/7. So the people who historically may have felt isolated in the situation where they're worried about something now have a security resource to as a backup for them.
And are there multiple people working on threat assessment? Like if I called and then Lori Green called 10 minutes later or 5 minutes later, would she have to waiting on hold, or?
If the person was still on the phone to you,
Mhm.
they would call Lori back after they had finished with you. In the off hours, during the on hours, it might be that there was a second person to answer that, and they work as a team as part of the assessment.
Mhm.
One of the people that work on the team has worked in law enforcement, but also worked at Napa State.
Kelly Kruger?
Yes, and Kelly,
Yeah, I saw that and I was thrilled to see her name there. I've
so
worked with them, yeah.
it's not just it's not a law enforcement
Mhm.
response. It's a more robust, holistic
Yeah.
security
Yeah.
threat assessment response.
Yeah. I mean, again, amazing and thorough and very impressive. As somebody who has called 311 few times, and I have no doubt that this is not going to be 311 kind of thing, but I certainly hope that none of the frustrating features about that will be attached to this. And I, just again, without having any expertise here, I'm a little concerned that somebody could be calling at night and then be placed on hold. I understand that you can't have unlimited staffing, but
Looking at the volume of calls we've received up to yet, that's not a problem that we perceive at this point, but this will be a PDSA, and as we implement it, if we see that there are high utilization times during the day, night, weekend, holidays,
mhm.
and low utilization, then we can adapt and be nimble around how we staff that.
If I may, Commissioner,
Please.
one of the data metrics from the threat management team is identifying every single call. So there've been 60, and that's how we know that only 4 went to voicemail. But I also want to make sure that we are reminding everyone that if it's an imminent threat, it's still 64911 or 911. And 64911 goes to our SOC. And so we're also collecting data on, now that we have socialized these 2 numbers, have the 64911 imminent threat calls increase as well. So we're tracking that just to make sure to differentiate between the 2.
Thank you. That's really helpful to know.
Those 2 boxes that you see on the slide have been pushed out to every DPH computer across the whole of the organization. So when you log into your computer, you've got those numbers in front of you, and we're working on getting badge buddies with the same information on them. There's a process that we need to go through for that, but there'll be badge buddies in the future.
Commissioner?
Is Susan done?
Oh, no, I think Susan.
I might have a
You
couple
have
of other, yeah.
Sure.
So you mentioned employees that do not have access to Epic. How do they report threats that they perceive in a way that would get to someone immediately to deal with it and then get into Epic if necessary?
So it would be, if they feel threatened, it would be the same numbers.
Okay.
So this is them reporting the threat that they feel. The Epic is reporting on the patient who could be a risk, which is why
Okay.
I mentioned from the clinical, like our food and nutrition, some of our food and nutrition or EVS, some of our food and nutrition do have access to Epic, like our dietitians, but some of our food EVS workers don't, like a porter would not. So the point of that comment was when we finalized the governance around the FYI flag, the assault risk flag in Epic, the thought was, how do we get the non-clinical team or the employees that don't have Epic, how do we get them notified as well? So that had to be considered. Some organizations do maybe put something on the outside of a patient room that's kind of discreet. But we're working through that so that everybody is informed and it's not just a subset of individuals who have the information on the patient that's at risk.
Thank
We
you.
also ensured that the threat management team have access to Epic with their own set of
Great.
my mind's gone blank as to the word, privilege as to what
Right.
they can see and what they can't.
Mhm.
But this information of the flag, they
Mhm.
can see that, and they can also know and see that about a patient when someone makes that call. The threat management team have the ability to see those flags in Epic too. So we thought that was super important. So if it had been a period of time between assessments, they would still have access to the real-time record in Epic to make sure that they were up to speed with what's happening with that patient. Obviously, they don't have access to PHI,
Sure.
but an appropriate level of access has been provided to that team as well.
Thank you. And I think the final question I have right now is, if there's a little more that you could tell us about the good work that Angelica Alameda and Stan Knight are doing.
I mean, honestly, it goes from it really does. It's such a gamut from group sessions to one-on-one counseling sessions to connecting people with other resources to giving advice on setting up these safe spaces that are being created across the environment. I will say that I had watched Emma Awodakunda and Tess Solstice, 2 of my my director of risk management and risk manager, work through the really difficult interview process and chart review, and saw them being really brave. And I reached out to Angelica and said, hey, can you just reach out to them and just check in? And she did that immediately within an hour of me making the ask. She had reached out to one of them, and another person on her team had reached out to the other, and just given them help and advice on grounding you know, and helping them to think through relaxing and not taking this work home with them, which is of course impossible, but, you know, just being super supportive. So it's really been innovative, and it has involved leadership from DPH all the way through to frontline staff. It's involved leadership from the Dean's office, not just at UCSF, but at UC level, with support from at that level to make sure that staff are getting whatever support they can be given in this process.
They're really meeting the staff where they are.
Yeah.
They really are.
And it's been so important that they've used a trauma-informed approach to the way that they hear and listen to what people are saying and feeling.
Well, thank you, and please give our thanks to your colleagues who are doing all that they can imagine to do to support their colleagues and ours.
Thank you.
Yeah, President.
Yes, well, again, thank you for the speed and depth of this work. And, you know, I remember a few meetings ago how diligent you've been, you know, reaching out nationally to try to find best practices. And, you know, thank you all for all the work you've done. And this is incredibly impressive. I just had a few probably completely disconnected questions, but so when do you think you'll get the badges for everyone with the numbers?
That team are working really hard on that. There are some production issues around and some agreement across the whole of DPH about what they're going to look like. There's some concerns around BHS about colours being triggering. So we've got to be really thoughtful about it, but I'm hoping that it will be, I don't want to give you a time frame because I don't want to be wrong, but I think sooner as opposed to longer would be better for us, and we're working to make that happen as quickly as possible.
And then you talked about being able to send an email. What about HIPAA protection? I mean, and again, what do you do with your EVS staff and people who are not? What is the mode of putting in a concern?
So it's an email. It's staff.safety@sfdph.org. The content of those emails has not, to the best of my knowledge, contained anything super sensitive. It's just been, hey, I work at this place and I think this would be a great idea, or I'm really worried about, like, there's a really dark alley at the side of Silver Avenue and the lighting's been broken, or we think it'd be really great to have a security guard all of the time. We think we need to be thoughtful about having a security guard all of the time, because it might stop some people who have had negative experience with law enforcement in accessing our care. So there's been it's been a real range, and the people who have been reading and answering those emails have worked with the planning section in the IMT to really think about the contents of those things in a themed manner. And as Sabrina said, we have come up with a number of themes,
27 themes.
27 themes that have been repeated again and again through these emails. But there's very little really sensitive information on them.
So if someone is concerned about an individual patient, either on the outpatient side or the inpatient side, how do they, is it always by that telephone contact? How do they flag that, or how do they communicate that they have some concerns about an individual they may have encountered?
That would be through the threat management team phone call.
Always the phone call then?
Right. So the email is more, this door doesn't work, or I feel like Adrian said, I would like to have more security presence. But if it's related to like a potential patient, then they call the threat management team, and then that's because we actually, all of the threat management team has a automated email response that says call the number, so that they can diagnose it when it's related to patients.
So no one would get confused that, you know, they're sending an email, just, well, the person shows up once a month here, but it would clearly indicate that it would go to threat management. Yeah. And then how often has the Evolve system been triggered? Have you?
Well, when we put the Evolve system up in 8090, we recognize, and we have reported this to you commissioners, the Evolve system is not 100%. And so there were a few complaints early on, you know, and we kind of worked through that. And it used to trigger several times an hour, even with eyeglasses. And now what we recognize after deploying it in 8090, that we probably could have enhance the other machines. So we've decreased the width and we've also upped the sensitivity. And so now that's causing I don't know the percentage, but it's probably like 75% of people walking through and getting, dinged. But what we're trying to do is reminding everyone, because what's worked well since we implemented it in Building 5 and 25 is, if you know you have a laptop and you know you have a glasses case and now it might trigger something else, if at all possible, hold it in your hand. And the cadets are trained to just look at that particular, item and let you go. I will admit that with the change, we are seeing delays, with entry into all the buildings, but we think that it's definitely necessary and it's going off much more now.
I have seen, as we've implemented standard work for the cadets to search when it goes off, that it's happening a lot more smoothly. We're getting through, and oftentimes it's the staff. If I walk through with my cell phone in my back pocket, I'll alarm. If I walk through with it in my hand, I don't. And it, I think that we're getting accustomed as a staff base to it, and the standard work for the cadets on how they search has been super helpful. So it's been a standardized approach to how patients and staff get approached.
So for example, if you have your glasses case, which does trigger it, and your laptop, which does trigger it, if you carry them up over your head like this, is it going to trigger it? Because the thing goes off, unless it's out of the range. And I also wonder whether you're, I'm sure you are, but auditing the people that are looking. I mean, I've walked through that thing, I don't know how many hundreds of times already, and they kind of, they barely look. I mean, how does it compare to the airport checkpoints in terms of people spending the time looking at what's in there? Because you'll go, oh, I have a glass case. Okay, bye. And they send you right through.
It's different to the airport, and it's different technology to the airport. So when you walk through, on the screen that they see, there's an orange box around wherever on your body or in your bag, it's picked it up. So if you've got things in your hand and the orange box is around your hand, that's when you're going to be waved through. Mm-hmm. If it's in a bag, they're going to want to look in the bag and make sure it is what they think it is. And then you get passed through pretty quickly. Yeah. And it's getting quicker, I think.
It is. And, we sometimes get new cadets every day. And so we just have to Adrian's point, the standard work, we just have to work with the sheriff's office to make sure that they're doing it appropriately. But technically, if you do have like your laptop or glasses case in your hand, if it does trigger, if you notice, the two cadets have a little monitor. And so it has, it'll alert to your hand, and then that's when, for the most part, they're like, okay, you can go through.
So I noticed the little screen we have is not very big for them to look at the bag. And I'm just wondering whether you've done any trials where maybe you have had someone go through with a knife or with something just to see.
We test, yes. We actually tested it several times. Just randomly, we have limited, types of weapons. Like, we're not going to bring a firearm on campus, but we've tried big kitchen knives, because sometimes there might be a party and, you have a kitchen knife, and we do it randomly. So like, I'll send some of my team out, the sheriffs will send some of their team out, kind of just randomly, just to kind of see, which aligns with the standard work, because we have to have continuous improvement to make sure that we are doing it consistently. So there are random tests that occur.
Great. And if you had to, you've done so much work. This is my last question. If you can identify the few things that you are instituting or are thinking about that might have prevented what happened to Alberto, what would they be? What would be the top things that you'd say, this could have made a difference?
Weapons detection, the robust threat management process, and the partnership with our 3 levels of security, with the sheriffs, with Marina, and with Allied on this campus, and having those regular check-ins and really focused on that. But the biggest piece is the threat management, that we can preempt and not. Weapons detection is important and it's helpful, but preempting that, because then it's really focused on many of our patients that behave in a certain way are behaving in a certain way because they're frustrated, but also because they may have underlying behavioral health issues going on. And if we can deal with either dissatisfaction, frustration, or an underlying condition or behavior before it gets to a point where it could cause harm to someone, that's always better. So making that threat management assessment more robust, I think, is the most effective way, because it's not just staff centered, it's not just safety centered, it's patient centered as well.
Thank you.
I think that was a great question. I think your response is really important for the reasons that you said. And an aspect of that, I think, is that, a person can be dangerous without a weapon that's going to, make the machine beat. And with these ongoing, this encouragement to employees and staff to note when they have, issues or a sense that this person could be dangerous no matter what, that goes into the system so that other people can be aware and people can just be alert. So I think that's incredibly important, because one of the things that I wondered is like, well, okay, so you're, great, you're doing this, these detection, but there are things that are lethal that won't throw off a detector. So if a person, you're not going to catch that with a detector. But if this person is somebody who someone has seen before and said, I don't really feel safe around them, I hope that you're encouraging staff to note those things as well without feeling that they are being overly cautious about someone or, doing something, putting a negative flag on somebody.
The communication that we put out is definitely, if you're concerned, let us know. And by taking a multidisciplinary approach to this, once the threat management team has done their assessment, there are 3 levels of response. And the first is focused on the patient's care team managing and setting expectations and drawing up a patient behavior contract and maintaining and the therapeutic relationship with the patient. Built into that is also a complaints and grievance process, so that if someone has a complaint and we can address that complaint and they can continue to receive care in a safe manner, we want to do that. We want to keep our patients coming to us for their healthcare as much as we can. So it being a multidisciplinary response is so important, and I think it addresses that.
And I think it's also important for people to remember, for staff to remember that, they're not necessarily doing a person a favor by ignoring signs, because that person could, get into some serious trouble that could have been averted perhaps or addressed before an incident. So there is doing no favor to somebody who might need some help.
Issue, maybe a bigger help to them than ignoring it.
Thank you for those comments and and thank you for your responses. So I'm beginning to see clearer. There is the security for our employees, and then there is the whole issue of patient safety and security on that. And so the latter is where you're trying to figure out patient flagging and so forth. And that seems to me very urgent in a sense, because those arise even more than Silver Avenue being dark. Which is important and which we could have taken care of a long time ago if you put more lights up, right? But how long do you think it's going to take? Because it sounds like you're giving very thorough thought on how to do this and yet do it appropriately. But at the same time, that really is sort of urgent, because if, number one, we had the right flags for this patient, then my follow-up question would be, what we're going to do with that. But first, we got to get to the flag.
Yeah.
So
The IMT structure is intended to ensure that we do this really expeditiously. And there's already there's already a policy draft for the FYI flags. The reason why it's actually taken this long, frankly, is because of all of the compounding factors, like the equity piece, because right now there's no governance and 90% of the flags are on Black men. It is also the complacency of the employee not saying, maybe this patient is okay, or maybe they're just complacent, with, whatever, fill in the blank. So that being said, in answer to your direct question is, I don't want to overpromise and underdeliver, but the policy team from an IMT structure meets several times a week, and I'll be surprised if that policy isn't submitted this week for.
I think it's slated for Thursday of this week. I will say that I have been with San Francisco Department of Public Health for a little over 7 years now, and even compared to COVID, which was something different, even though we're using the same structure. Even considering the way that we moved fast in COVID, I have not, in my time here, and other people have worked here much longer than me and may feel differently, but in my time here, I have not seen the solidarity and the coming together and the determination to make change happen, and balancing it with it not being a knee-jerk firefighting reaction and it being something that can be sustained and has equity embedded into it and addresses bias and thinks through all the different parts of DPH that it has to affect and the different needs and the different ways that care is documented in behavioral health compared to pop health, compared to DPH. And I think that I have not seen this level of organization in the time that I've worked here outside of the ZSFG. I'm incredibly proud to work at ZSFG, and I think that we have been a model for some of this work, and it happened on our campus, and we needed more people to help us to make this happen quickly.
So you think by our next meeting, you're going to have an answer to this?
I think by our next meeting, we'll have the policy at a minimum, at least in draft form.
Right. Is there any sort of interim that you're going to place, maybe in terms of, say, somebody again feels very uncomfortable about a patient who looks bad? I mean, is it just this emergency call that you're using? That's what.
I think in the interim, it is the threat
Okay.
management and encouraging all staff to use the threat management.
All right, because that's really important because
that's how we get a response.
you know, I mean, we can get to a perfect system maybe, but that's going to, lose some time. So the second issue was communication. It seemed to me when we're just sort of lay people reading the case, right? That it just didn't get communicated correctly. And there was protection for the physician who was under threat, but there was no real focus on the patient itself who was ill and needed, I guess, more immediate attention. So I assume that Marina Security is a security company then, and not referring to the marina in that. So I got that. So now we have Marina Security on campus, and we've also got the cadets. And we have the police department.
We have the sheriffs.
And the sheriff. So, so is there then a process going on to try to see if they really communicate with each other? Because it looks like this is not our only example nationally for these things not going right? A lot of what you're reading about seems to be a lack of communication between the different agencies doing things.
Right.
And sometimes a very tragic, results like this, unfortunately. So how did you improve the communication so that if this event were to occur again, that the right people would have been notified, or is that still in progress?
So we shone a really bright light on it and looked at what we were doing currently, and we had some areas that we were doing a really great job at. ZSFG, we met on a weekly basis with the Sheriff's Department and Basil Price. And we had recently had our security partners join those meetings along with clinical folk. And that model is going to be spread across DPH. So that a weekly meeting that has law enforcement, security enforcement, clinical and administrative leadership at the table together talking about security across DPH is part of the governance structure. So I think that communication piece there is super important. And those threat management cases that have risen to a certain level as part of the standard work within the threat management team will be presented at those meetings. So there's total transparency on where our threats and opportunities are.
But that's kind of, after the fact from what you're saying, if you're having meetings on people that may have been a threat and so forth, how do we deal with a situation that really sort of occurred in which the person apparently, came into the clinic, was searching for the physician and then decided that he was going to figure out a different way of finding him?
So prior state, there's a lot of information out there about the prior state, and through our regulatory governance process in March, you will hear the findings of the root cause in closed session. I will say that I'm going to give you the same answer again, and that's that the super robust threat management process that we've put in place isn't a one-time touch base with a staff member who's concerned. It's an ongoing relationship with closed loop communication to the person who raised the threat and to the leadership of the department where that threat happened, and through investigation with all of those people, if that patient or the person making that threat has relationships with multiple clinics across DPH, those leaders in those clinics will also be alerted. And the threat management team is the absolute key to that closed loop communication around when there are concerns, threats, or needs for support for staff and patients.
They're the nucleus, basically. And so their job is to inform all the different law enforcement agencies, because as you mentioned, there could be a jurisdiction question. We have UCPD, there's SFPD, there's SFSO, we have Marina, we have Allied. The threat management team has built those relationships with all of the contracted security, as well as law enforcement, as well as all of the clinical leaders. Part of the policy that's already been reviewed and approved is how they communicate effectively to close the loop in a timely manner.
Okay, so I think at our next meeting, a follow-up could be, given to us as to how the progress, I guess, of and the effectiveness of the threat team, the threat management team. Is that what we're calling it? Okay. And also the progress going on in regards to the areas that you are outlining that you're getting from the emails that sort of highlight areas which we may have forgotten, like the alley or whatever it may be, so that we can see that there is some tangible movement on both sides. I see that Dr. Ehrlich, I think, might wish to contribute to this dialogue.
Thank you, Dr. Chow. I just want to give a lot of gratitude to these two for all of the work they're doing. I agree with Adrian that the system that we have in place now, the threat management system, how robust it is, that it's a closed loop system, is a really effective measure for right now. And it gives us a chance to see over time how it functions. And, it's working so far, I think, for the people who are calling, and there's a lot of information out there. Anytime you log into the computer, you see those numbers. You log into Epic, you see those numbers. So there's a lot. And the fact that almost 4,000 people have written emails to the staff.safety, it shows that people are engaged.
Very good. No, I think that's reassuring, and to be able then to see the progress that will be made in our coming meeting would be, I think, appropriate in terms of maintaining it on a agenda. Thank you very much. And thank everybody and the entire team for the, amount of work and the thoughtfulness. And I think we thank the director for really making this a department-wide issue. And it's just not isolated, and taking into consideration the safety of our employees, along with how are we going to help our patients when they are really in greatest need right then, in terms of their own behavior. So really appreciate your work, and we'll look forward to a update. Thank you.
Commissioner Chow, would you prefer to have the update as its own item, or could it be rolled up in the CO report? Does it matter to you?
Well, I think the item is still under development, so it's not just simply a written report, but I think the ability for the commission to be able to get I guess an overall feeling as to how this is working, not just a report. I think, for example, Dr. Ehrlich's summary was so helpful, and we wouldn't get that just simply from a report.
All right, so we'll keep it as a separate item for maybe the next meeting,
Yeah, I
whatever you
think-
all have. Okay, great.
Until it gets to a point where then it's really in place, and then we could be looking at reports as to, just like with the BERT team,
Sure, no, of course.
how it is doing and what we're learning from it.
All right, thank you.
So I'd appreciate that there be an update that gives us a chance to really inquire into it.
Okay, thank you.
Thank you.
We move on to the next item. Is that all right? Or
Yes,
any other
please.
comments, questions? Item 7 is the medical staff report.
Good afternoon, Commissioners. Happy New Year. Mary Mercer, Chief of the Medical Staff. I am very pleased to present to you the medical staff reports for December and January. And as you can see, we had a very full report with multiple services presenting due to some illnesses from the prior month, and also a number of privileges and standardized procedures to update. And given the time and also the density of the report, I will be very succinct in summarizing the 3 service reports, and we'll skip ahead to your questions that you sent in. Thank you for sending those. So just in summary, we reviewed the obstetrics and gynecology report, the oral maxillofacial surgery report, and the anesthesiology report. And all 3 service reports really demonstrate the unique blend of clinical service, education, and research, and discussed both the impacts of those as well as kind of the headwinds that a number of those areas are also facing given our medical policy climate nationally. But really had a lot to celebrate at the same time with a number of the services, all 3 of them relying on interdisciplinary teams such as the nurse midwives, our dentist colleagues, and CRNA colleagues that really help to support those services. I'm happy to take additional questions for the report, but I can go into the questions that were sent with regards to those 3 services and the privileges and standardized procedures that were sent along with them. So just looking at the OB staff report and the privileges that were sent, there were several that we did, and for all of these, we did send the questions to the service leaders. Some of them have been in the operating room or in clinical care today, and so I don't have all of the answers to the questions, but we will definitely follow up after today with answers to some of the questions. Thank you, President Green, for sharing the feedback around fetal scalp sampling, and we will address that with Dr. Jackson. And additionally, the stars or the asterisks next to the inpatient obstetrical procedure care procedures will clarify what those are, what that was meant to indicate. There was a question about episiotomy repair for 1st and 2nd degree lacerations versus 3rd and 4th degree lacerations. And I think, as you noted, in the privileging reappointment criteria, there's a requirement for 15 procedures within the list of procedures over the course of 2 years, but recognizing that every case is different. And so you may not have an opportunity to perform one type of repair versus another. They grouped them separately. The more complex repairs being their own category, separate from the common repairs. And then we'll clarify regarding the hernia repairs, if those are outside of general surgery options, as well as changing the Assure training device. For the dental report, there were some questions around the collection rate and versus the charge rate. And so I did hear back from Dr. Bast, who is both the chair of the Department of OMFS, as well as the chief at the general. But I will also note that all of these service chiefs have done a great job of succession planning and looking ahead to really recruiting great leaders. He clarified that due to Medi-Cal rates, the procedure clinic, the outpatient procedure volume has continued to grow for the dental clinic. And there are a number of patients that need tooth extractions that choose to self-pay because those are not necessarily covered under Medi-Cal reimbursements. But because at the point at which people are needing dental or able to access dental care, they need an extraction. So there are a number of self-pay clients in there, and so collections are not the same as what they are with Medi-Cal. In the anesthesia packet, again, we sent a number of questions to Dr. Paracchio and team, and so we'll send more of these back to you once we get the full responses. You very ably noted that the data that was shared in this current report was for the 2022 to 2023 period versus as opposed to the 2023 to 24. And some of that is due to their data team backlog. And so they're updating their data on some of those efforts, but the improvement efforts are continuing in those areas that were noted. They do have TXA. They do have easily accessible TXA, and I don't know why that wasn't listed on that report, but we'll clarify with them and so that they can update that list. And there's a general question around just the process for overseeing both the reappointment or new procedures or standardized procedures being added for either medical staff or affiliated professionals. So those would be, non-physicians or dentists or others like clinical pharmacists who operate under standardized procedures. There is a statewide effort where many specialties are moving towards privileges, which will be separate from standardized procedures, but the process by which someone is approved and supervised will remain the same. That the supervisor, if we're coming in as a new appointment or if you are being reappointed with a privilege or a standardized procedure, if you're adding a new privilege or standardized procedure, it's essentially the equivalent of a new appointment. You have to have a certain number of proctored cases. You're not just reappointed with the new procedures or privileges without appropriate proctoring or review. We are waiting on the response around the particular point of care urine pregnancy test device that is used, and we will get that to you over email. And then, the question asked around how do we test for toxicology test if someone has altered mental status, and this really falls under a whole range of care issues, and that we will not proceed to obtain blood or urine requests from a patient unless they have the ability to consent or if there is an emergency condition. So if someone is having an emergency, is unconscious and having an emergency C-section, they might receive a Foley catheter and it might be, obtained that way. But otherwise, we wait until the person has decision-making capacity and can consent to engage in care. There are some things that were for closed session, which I'm happy to update about in the closed session. And thank you, Commissioner Chow, for pointing out the language around the ACIP and or CDPH clarification under the standardized procedure for clinical pharmacists in the administration of vaccines. We will work with the team to update that language, but I think it does speak, they left an or in there because as you know, the way the kind of chain of command for public health related orders flows from the state authority. So CDPH really sets the regulations for medical practice within the state of California. And so as a health system, as a health department, health system, we are accountable to CDPH, which often adopts the recommendations given by ACIP. But as you noted, given the changes at the national level and the CDC in terms of the Committee for Immunization Practice, the state of California has elected to participate in the Western States Alliance regarding vaccine recommendations. So we still, as a healthcare entity, take our recommendations from the state of California primarily, but they often do come out of the National Committee for Immunization Practice. And I think, yes.
So I think that because of the way it's worded, which is what I was getting to, it says, and published by the federal CDC, and I think that would be in error. I think if we just simply said the state of California or CDPH, then we should just stop there. You could stop there because we have so many different groups now who are
thank you for that,
putting out their and that's just to clarify, not just in that one section, but several of the sections carry that. And you may have other areas that actually talk about vaccines that we're going to have to modify in order, again, to follow the state of California. I think Dr. Erica Pan gave a very nice webinar actually the other day in regards to how the state was doing it. But I don't think you have to name all of those. I think just CDPH would do.
We'll stop at CDPH and we will look in our other sets of privileges for the other clinical services to see where it might reference that. Thank you. And I think that the follow-up after that was similar. So I'm happy to take any additional questions that you may have about the service reports or the privileges or standardized procedures.
Were there any questions?
Thank you for the report. I don't have any, I have one question, but first I just wanted to note the strength of the research and the publications. I mean, I don't know, but it seems pretty impressive to me. I don't know if you have anything more that you want to say about that.
Yes, I mean, we attract real clinicians that are both excellent clinicians focused on a mission to reduce health disparities, as we've mentioned in previous presentations. A lot of that drives a lot of the work that is done at San Francisco General. I will particularly point out that of the services presenting now, the OBGYN service, which has really advanced care internationally in terms of maternal fetal care and prevention and health outcomes, has probably suffered proportionally some of the greatest amounts. So they had some researchers and clinicians who are based out of the General who were part of the USAID, and so had their grant funding significantly impacted and eliminated early on in this year. And so the service has been working with them, and it really just speaks to the unfortunate absence of the impact that they had been having globally because of that fantastic research. So we continue the work here locally as best we can and with other partners. But I think it's a challenging time to be a researcher in these groups.
Is there any way to quantify that a little bit, that challenge, that loss?
Yes, I don't have the exact number in front of me, but I can get that for you.
And the final question I had was the image on the front page of the OBGYN report. Is that a cervix?
No, that is actually a laparoscopic. I believe I don't have it in front of me because I didn't print it out, but if I remember, there's a intraoperative surgical picture, which I believe is a uterus and a fallopian tubes and ovaries from a laparoscopic view.
Okay, she could tell me.
So yeah, yes, if that's in front of you, if I recall.
Thank you for the significant report.
Any other questions? Okay, so there not being any other questions, I don't know what we're going to do with these, 30 pages of, no, 30 items and multiple pages. How do you want to present those?
Yes, I mean, so I can present them in detail. There were summaries. Most of them were many of them were administrative changes. There were some that were addressing additional functions that were performed within each of the areas. I'm happy to take questions about them. I think that might be the best way, but I'm happy also to go through them
And-
by item.
And if I,
Would see if we have any questions within those items, if there are any that were not forwarded. And, there are none. So I guess the only one I had was still this same question in terms of the wording. I'd hate to see that wording about the vaccinations go through the way it is.
Yes, so we will definitely bring that back to each of the clinical areas, and we will have to crosswalk it with some of the others, like family practice and other areas where vaccines are administered, but certainly in the emergency department standardized procedures, I don't know if you wanted, when you make a motion, if you want to make a motion with that ACIP removed, we can certainly offer that as an option, and then we could send you the updated standardized procedure with the question responses that we have pending from the Truth of Service.
Yeah, I'd like to see that one sort of moved aside or removed as, and that you come back with language then, because I'd hate us to pass something that
Sure.
then would, I think, potentially jeopardize people if they didn't follow the ACIP as published by, see, my problem with wording is published by the CDC, because CDC didn't publish CDPH.
Right. We can remove the emergency medicine pharmacist standardized procedures from the list of 19.
There's also two things on the OBGYN. There's two on the OBGYN.
I'm sorry.
There are two things on OBGYN. One is a fetal scalp sampling. The other is assure training, which I'm sure can go away because the device went away.
Okay, do you want them to change the wording?
Yeah, if they could look at those. I think those are the two.
Yes, they are.
I don't think we do fetal scalp sampling anymore, and I know they don't do assure anymore. Last year we got rid of hysteroscopic sterilization, but this is training for hysteroscopic sterilization, so that should go too.
Okay, so just to clarify, we did send those back to the service today with the feedback, but I don't have them a new version back. Would you like us to remove that from consideration today, and then we'll include it in February's?
Well, I
Or
hate to not,
just remove those two. And
just those two, because I have a feeling it's good. They're both going to be omissions.
Mhm. Yes.
So it's not like they have to alter the policy. It's not like the ACIP. So I think we can assume that that'll just happen and we can approve knowing that the department will consider that.
just for my notes, could you tell me the two policies that's on?
Well, it was on page 22 of the OB, it's fetal scalp sampling, and
Okay.
page 25 to 6, where it's assure training.
Thank you.
Yes.
And I will take the emergency standard procedures for the pharmacy off of the list that the full commission will approve.
Right. So with that, then we have the remaining policies. Are there any other changes that are needed? Okay. So a motion's in order to accept all the remaining policies and
So
recommend
moved.
them to the commission.
Second.
All in favor, please say aye.
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 Thank you.
Thank you.
And congratulations on doing that so expeditiously and thoroughly at the same time.
Well, I do want to congratulate my, or thank my fellow commissioners for the review that they were able to get through over the weekend. I'm sure that, well, we didn't have to watch the 49ers, so.
That's right. That was the pivotal component.
All right, thank you, though. We can move on to other business. Hearing none, we can, and public comments already been done. We can move to consideration for closed session. Could someone get the back door when y'all?
Yes, a
Thank-
motion for a closed session is in order.
So moved.
Second.
All in favor, please say aye.
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 All right, great. Please give me 30 seconds to switch us over. I do. An open session, commissioners, you, in closed session, you approved the credentials report and the October, November, and December 2025 PIPS minutes reports. Please consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
Second.
All those in favor?
Aye.
Did we not also approve the credentials report? Did you
I,
say?
I thought I said that too.
Okay,
Yes, I
I
think
just wanted to
credentials
make
and then I
sure.
did the list of, yes,
Okay.
but I'll make sure the minutes note that.
Great.
And please consider a motion for adjournment.
So moved.
Second.
All in favor, say aye.
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 Thank you,
Thank you very much, everybody.
Thank you.